just like to acknowledge my co-authors. So melanoma is the third most common cancer in New South Wales, and about 13% of people that have cancer have a melanoma. So we were interested, so we know that there's a group of people who are at very high risk of melanoma, and these are people who have a strong family history. They may have had multiple melanomas, they may have many moles, or they may carry a genetic mutation. And there's been a number of studies that have looked at how best to manage this group of people. So a protocol was established at Royal Prince Alfred Hospital, and in addition to the normal full skin examination, they use total body photography, and they also use sequential dermoscopy imaging. And this is when a lesion is identified and they're not really too sure how to manage it, but they take an image of the lesion, and then the patient is asked to return in 3 months, and they compare the lesion and make a decision. So one of the main findings of this protocol was that there was a very low benign to malignant excision ratio. That is, the number of lesions they had to excise to detect a melanoma was very low. So as a way of progressing this forward, we were interested in how we could translate these findings into clinical practice. So in the first part of the study was actually to do a microcosting study where we costed the high-risk clinic, and then we did a cost-effectiveness study. And then moving on from that, we did a budget impact analysis. So we had to, as part of that, we had to describe how we would identify patients at very high risk. We had to estimate what was this high-risk population, and we also had to look at the costs and savings of this program. And we also looked at what would be, I guess, other issues that would influence specialists and general practitioners to carry out specialised surveillance in the community. I guess so the barriers and the enablers, I guess. So these are the results. So in the top corner, you can see the results of the cost-effectiveness analysis. So we used clinical data, and we used a linked data set for routine care in the community. And what we found, so this is I haven't got a pointer, but basically so the little dots are the results of the probabilistic sensitivity analysis. And it sits on a cost-effectiveness plane, and due to time limitations, basically what this shows is that patients that are monitored using specialised surveillance compared to routine care, it's much more effective, and it's also cost less to use this type of specialised surveillance. And the main reasons for that are that melanomas are detected at an earlier stage and that there are less excisions. So moving on from that, we then developed so then the other results for the budget impact analysis. So the first, the table shows the number of people we estimate that would be at high risk based on a melanoma diagnosis. So we used national data for incidence of melanoma, and then we used published literature to actually figure out how many people would be at highest risk of melanoma. And we actually decided to use the time of diagnosis for our modelling, because it's a time when people have their family history taken, they have a skin examination and their medical history. So we actually did our modelling on this. So the last little line graph is the results of the budget impact analysis, and you've got years on the horizontal axis and thousands, hundreds of millions of dollars, just millions of dollars on the vertical axis. And so these are the costs over 5 years, and so basically the cumulative cost for specialised surveillance is about $93 million, and for routine care it's about $120 million, so therefore the savings about $27 million. Oh, there's the two little lines, sorry, the other lower lines, we actually, when we modelled it, we modelled everybody could receive, all eligible patients could receive specialised surveillance, and the other one was that there was a gradual uptake of specialised surveillance, and you can see that they're quite similar. So the further implications of how could we transfer this model, we believe that it is transferable because the technology is already being used. We believe there are issues related to access, and we think that MBS item numbers would mean that would help patients out-of-pocket costs, because currently patients have out-of-pocket costs, and this model is time-consuming for both the doctors and the patients. We are currently involved in a MSAC application with the College of Dermatologists for MBS item numbers. We'd like to get more evidence for general practitioners, so we could also submit a similar application, and we think that further research is required for excision rates in other clinical settings.